So one of the things that I always try to tell everyone when it comes to your 12 lead is just like when I was trying to teach you lead 2 and trying to teach you on the looking at the strip and kind of understanding the location of, not just that the P wave is atrial depolarization and not just that the QRS is ventricular depolarization, but really understanding the location of the heart and where, those particular things are occurring. So with a 12 lead, you're going to look at those aspects, but you're also going to look at, I know it's not the right term, but it's I like to use the term the geographical location, because I like to look at a 12 lead as a map of my left ventricle. And when I say geographic location, then that kind of relates that with, the location. Now, we could say anatomical location or whatever. But with your 12 lead, what you're actually seeing is you're seeing 6 leads that are on what's called the frontal plane, which is up and down. So somebody chime in and tell me lead 2 is on the frontal plane. Where is your negative and positive in lead 2? Who can remember that? Don't be shy.
Are you asking about as far as like the bipolar leads? Where are they?
Yeah, for lead 2, lead 2 right here, and Eric just answered it. But where is your negative and your positive? Because remember, it's going to be important that you remember that in your positive, that's what's that's where you're looking at for the direction of the lead. So when you have a positive lead, so y'all answered it just a minute ago, lead 2. So you said you could see my screen. So lead 2, where I'm circling here with my mouse, lead 2. The positive is my left leg, and the negative is my right shoulder. So my QRS is upright. So that tells me that my direction of travel is towards the positive here. So it's my shoulder will be negative here. So it's showing me that it's going towards that. So that's going to be important that you understand that concept, that anytime a conduction travels towards a positive, you're going to see an upright deflection. Anytime it travels away, you're going to see a negative deflection. Now, the reason why that's important is because you're looking at one conduction, but you're looking at essentially 12 different camera views. That's the thing that I kept mentioning in the lectures. All right. And you're looking at 12 different camera views with 6 of them on one plane. Everybody except one, and we had to call in. So he's listening right now. So, but I'm also recording it too. So, just to let you guys know, you guys are the very first in the school doing this Google Meet thing today, because the school just opened. So I've had the dean and my boss, Mr. Simpson, both in here asking how things are going. So I'm sorry about that. But so leads 1 through 1, 2, 3, AVR, AVL, AVF. I said that's frontal plane. And then V1 through V6 is horizontal plane, meaning that it actually goes from the inside. So your inside, V1 through V6, they all have the same negative, and they're looking at different areas of your left ventricle to start with. Now, one of the things that I wanted you to do, one of the reasons why I wanted to print off this 12 lead, and if we were in class right now, I would certainly have, we would be doing this activity, but and I will actually take a picture of mine and upload it at a later time. But you're going to have to be patient with me here too, because I'm having to draw with a mouse instead of a whiteboard. But what I want you to do is we've got to look at what's called contiguous leads, or leads that look at the same area on the map. All right. And in order to determine that, we need to determine where each one is looking. And so when I do this activity, what I always do is I get you to start with leads 2, 3, and AVF. 2, 3, and AVF. All right. Now, what I'm going to do is over here, I'm going to draw a circle. Nope, I'm not either, because it's not going to let me on that part itself. Okay. Okay. Um, let's see if it'll let me do it here. All right. So I'm going to draw a circle here. All right. That's not a circle, but it's close. All right. What I'm going to do, all right, so we've talked about the axis stuff and all that. So I'm going to show you based off of this. So imagine this circle that I'm seeing right here is actually circling the left ventricle. All right, everybody's following me. So lead AVF is so hard to draw like this. All right. The positive is at a 90 degrees. So if you imagine this was a perfect circle. All right. So this is AVF. All right. Then lead 2, your positive is like at a 60 degrees. All right. And then lead 3 is at 120 degrees. All right. Now, in terms of medical terminology, if this was the left ventricle right here, all right, you would say that all of these are on the bottom. All of these are on the bottom of it, or the inferior portion of the walls, right? So these are your inferior leads. So your positives are here. So what they're looking at is the conduction from each of these vantage points. Okay. So leads 2, 3, and AVF, these are your inferior leads. Okay. So you can write inferior there. Okay. All right. Now, you want to look at. I'm double checking over here to make sure nobody's like chatted or anything. Now you want to go here, circle lead 1 and AVL. All right, lead 1 and AVL, and these are going to be high lateral. Okay. Leanne, you good? It just popped up. I see you. So, all right. So this is high lateral. So what does that mean? All right. So again, we're looking at the left ventricle for right now. All right. And so lead 1 is at 0 degrees. Okay. That's lead 1. All right. And then lead AVL is going to be at a negative 30 degrees. All right. All right, so these would be the higher portions of the left wall of your left ventricle. All right, so if I had some issues in leads 1 or AVL, I would certainly want to come over to V5 and V6, which we're talking about lateral, so I'm going to go ahead and tell you to circle those as well. All right, V5 and V6, because that is low lateral. So it's a lower portion of the left ventricular wall. All right. So then you've got AVR. All right. AVR, I'm just going to circle in a different color, just so that right now you can just see where it comes in as part of the hexaxial reference system, but its positive is way up here on the right side, and it really doesn't give us a lot of valuable information when it comes to reading the 12 lead and what we need, because again, our main focus is going to be where we at with there's Walker, where are we at with the lower ventricles, the things that are important to pump blood to the left side of the heart and the rest of the body. Okay, so AVR right here, and it's at a negative 120 degrees. Okay, so this is really just, you know, the degrees of a circle, and you've got a complete circle, and basically what we're looking at is the angle in which the electrical conduction is traveling. Now, here's the deal with this. We want it to be within this area right here, which is 0 to 90 degrees. Now, I know that in math you go from 0 all the way to 360 degrees when it comes to the numbers and stuff, but did Leanne get it fixed? But for these reasons, we go from a 0 to a positive 180, and then 0 to a negative 180. All right. So the top portion is going to be negative, the bottom portion is going to be positive. Okay. Now, I just wanted to show you that in relation to where this axis stuff comes from and all that. Now, when it comes to that hexaxial reference system, that only includes these leads right here. Leads 1, 2, 3, AVR, AVL, and AVF. Okay. Your V1 through V6, they're not part of this hexaxial reference system. And if we were in class, I would ask you why. And the reason why is because they're on two different planes. All right. I see Leanne's having to restart her computer. But they're on two different planes, okay? So now I'm going to just erase this up here because I need to get a little bit of room. So, I don't want to erase all ink. I don't guess I will erase right now. All right, so now I want you to go to V1 and V2. V1 and V2 and circle those. And these are going to be your septal leads. All right, your septal leads. So your septal leads, they're going to be right over the interventricular septum, and they're going to go on down and actually have a little bit of pickup in the anterior leads, which are going to be the ones that are left over, and that's V3 and V4. All right, so the anterior lead, so we're talking about anterior of the left ventricular wall. Okay, so at this point, I would ask you, why in the world is it important for us to look at all of these areas on the left ventricle first? And you're probably saying in your head, because I've conditioned you to say this, cardiac output. I hope at least you have cardiac output, because the left ventricle is going to be the most important when it comes to cardiac output. And so obviously, we know that from our anatomy lesson that the LCA feeds into several vessels that bifurcate off of it, and it pretty much feeds 80% of the left ventricle or the heart. And so we definitely want to see the left side is going to give us the best indication if you've got LCA occlusion for sure, because that's been part of the cardiac arrest. That's a big causative agent of cardiac arrest in MI. Now, what we're seeing here is just pretty much a normal 12 lead. It does say that it's got some borderline depression in the anterolateral leads, and again, that was just something that I had mentioned in one of the lectures. You want to make sure that you are able to read these too, and not just have to depend on what this prints off. I would just turn this in to the doc and take them, unless they were having chest pain or whatever. I would just take them in as a patient that pretty much has a normal ECG. Okay, so on if you also think about the fact that with an electrical diagnostic tool like the EKG, we can really only look at the electrical conduction. So nothing's really changed there. But what we can have is indications based off of what we see from what's happening with the depolarization, repolarization, and the conduction pathways in those particular areas. We can kind of get an idea of what's happening with the muscle wall and what's happening with the vessels. So, with the inferior wall of the left ventricle, it's mainly being fed by your RCA. Now, of course, everybody's anatomy is a little bit different, but it's mainly being fed by your RCA, where most of the leads V1 through V6, those are going to be fed by the LCA or some variant of the LCA, such as the left anterior descending or the left obtuse or something like that. All right. Um, and then your high lateral, your 1 and AVL, that's often fed by what's called the circumflex artery. Now, here's the thing with AVR. Now, it does have some diagnostic benefit, but not in early learning of 12 lead recognition and all of that. All right. Um, so, knowing leads 1 AVL, V5 and V6, those are your lateral leads. RCA or leads 2, 3, and AVF, those are your inferior leads. V1 and V2, those are your septal leads, and then V3 and V4 are your anterior leads. Okay? Now, hey, question? Eric, you have a question? Okay. All right, cool. I thought somebody was asking a question. Are V1 and V2 also anterior leads? So they are. They officially V3 and V4 are anterior leads, but V1 and V2 could be considered because of they're looking at the septal wall, which is part of the anterior wall. But we like to differentiate V1 and V2, especially V1 as septal leads, because they do look over the interventricular septum and they can tell you a little bit more information about what's going on as far as like with bundle branch blocks and actual conduction disturbances right there at the bundle and all of that. A lot more than what your V3 and V4 could tell you. So, a lot of times you will see issues with your septal and anterior leads together. So I don't know if y'all saw the question Dom asked, but he said are V1 and V2 also anterior leads? So that's what I'm answering right now. But sometimes you'll see like anteroseptal MIs and all of that, which is actually one of the examples I use. But it is very important to differentiate here that you understand that this, especially this one here, because this V1 is where we're going to actually diagnose. And I use the word diagnose very loosely here, but we're actually going to diagnose bundle branch block, both right and left bundle branch block. So, that answer your question, Dom? I mean, y'all can unmute yourself and say yes too if you want to. Okay. So,
I have a question
hey,
really quick.
uh huh.
So V2, 3, and AVF are right side, and V3 and V4 are left side.
Um, hold on just a minute. I'm going to let me grab my phone. All right, I'm going to bring it back over to my camera here. I think. Can y'all see me?
No.
You're still in the small box on the top right of the screen.
Okay.
If you just lift up the heart a little more, we'll be able to see it. Oh, there you go.
Can y'all see me now?
Yes.
Yes.
All right.
Yes.
So let me. I'm doing my best here, guys. There's a lot of lighting here needs to be done on my part. I apologize, but all right. So if this is my heart right here, I know that this is really weird because we're looking at it from several different perspectives. And so, actually, Jabal, I'm going in to answer this question right now for you. So, if this is my heart right here, and then this is my left ventricle, you're asking 2, 3, and AVF, are they right and all that? Actually, what you're looking at would be the inferior wall, which is the bottom portion of the wall, which would include maybe a little bit of the right ventricle. All right, which is why we will talk about, and we have talked about in the past, if you have inferior wall involvement, you want to do move your V4, which would be moved over here so that it could actually get a look at this side of the ventricle. All right, see if you got right side involvement, but it has a large portion of the left side involved. All right, and then if you're looking at leads 1 and AVL, remember I said those are high lateral. Those are high lateral. So here's my left ventricle. So they're essentially looking, and it would be so much better, but it's not a luxury we have, so I quit being like that. But if we were in person, but so it's actually looking like lead 1 would be looking like in this general area right here, and AVL would be looking more up here. All right, so that's your high lateral, and then V5 and V6, that's your low lateral. So they're actually going to be, they would be placed like V5 and V6 would be placed right there, and they would actually be looking on this part here. So kind of V5 or V6 and V5 would be more right there, to where they kind of, you know, about where the inferior leads and V5, they would kind of, meet up right in there. Then you've got your septal leads. And so this is what I was saying that was so important earlier, Dom, on your question, is that V1 and V2. So if you can imagine this was in my chest, V1 is going to read like this off of your septum here. V2 is going to read there, all right? V3 and V4 is going to read anterior wall, which is the front part here. Now, one of the limitations that before I move on, Jabbar, did that answer your question?
Not really, but I get what you're saying.
Okay.
I get what you're saying, though.
So what are you asking then? I mean,
I guess because on the ECG paper, when it prints out, how you were saying it, how you can tell if it's a right block or a left block. I guess that was my ultimate question, just trying to see if we can see that on the 12 lead as well, which side of the heart it's affecting.
So you can, but the only definitive way to do that is going to be for them to obviously go to cath lab or something like that. But you can, in most people's anatomy, that inferior leads there, in most people's anatomy, is being fed by the right coronary artery, and then most of the V leads are being fed by the left coronary artery. And so that kind of goes back to what I was saying earlier, why it's very important that we get these leads on and kind of get a good look around. Bottom line is, though, I don't want to say it doesn't matter, but if folks are having chest pain and we're seeing ECG changes and all that, time is muscle, so we want to make sure that we're getting, we're getting them to where they need to go, even if whether it's an inferior or septolateral or whatever. But yeah, it does give you a little bit of an idea of the anatomy there. And again, this is just electrical conduction. But if a coronary artery is blocked and you start having lack of blood flow, they're going to have decreased perfusion, and then ischemic and injured tissue cannot use electricity, and so you will see changes. That's why you see the changes in the ST segment and all of that. Okay.
Okay.
All right. So one of the limitations of 12 lead, as we have it, is that you can't see a posterior view. You've got your lateral, you've got your septal, your anterior, and you can even get a right-sided view. You could get an in-depth right-sided view if you moved all of your leads over. But for quick diagnostic measures in the field, just doing the V4R will tell you what you need to know as far as whether you need to use nitrates or not. There are ways to kind of get an idea if you've got a posterior issue or not, and that's through the idea of reciprocal leads. Reciprocal leads are going to be the opposite of contiguous leads. Okay, so contiguous leads are going to be leads that look in the same area. All right. Your contiguous leads, you've got to identify at least, your contiguous leads. You want to see ST segment elevation and all of that in at least 3 leads. And so I would even, I would say that, hey, if I've got V1 and V2, V3 would be a contiguous lead to V2 as well. All right. Because they're still in the same general area. Even V4 and V5, you'll often see them all kind of interrelated there. But the reciprocal leads, they've got the camera on the other side of the heart. All right. So let's say for leads 2, 3, and AVF, your reciprocal lead or your opposite lead, and I'm just going to go with just that for right now, is lead 1 in AVL. So one of the things that I want to look for, if I have ST elevation in leads 2, 3, and AVF, one way to confirm that I've got STEMI is that I'm actually going to have ST depression in leads 1 and ABL, because they're looking at a different place. So if for lead 2 my camera is here, and then lead 3 my camera is here looking at it going that way, and then AVF my camera is here, so those are contiguous, they're all there. So lead 1 my camera is here, so it's getting, if that conduction is going this way, it's going to get this vantage point of it, and then it's going lead 3 is going to get that vantage point of it, and then AVL is at essentially the direct opposite of lead 3 right there. So if you see something going up here, you should see it going down there. Okay, so that's kind of the idea of reciprocal leads. Okay, now no, that's not the easiest to understand, and I'm certainly understanding, where you guys are coming from in that aspect. So it's going to be very important that you do watch those lectures, and then I posted those by the resuscitationist. There's 6 of them I put in a module that I do have that you must complete there. But that will help you understand that more. Okay. So one of the most important things again here is going to be understanding how this is laid out. So you need to, just as you're getting more proficient now with your lead 2 interpretation, where you can get a strip and set it in front of you, and kind of quickly look at it. That's what you need to do with a 12 lead as you move forward, is you need to be able to get that printed out and look at it and say, hey, these are my inferior leads. I've got inferior issues, or these are my septal leads, or something like that. Now, we will eventually get to bundle branch block and be more in depth with it, and V1 is going to be where you would look at for your bundle branch blocks. So, are there any questions on that before I move forward with anything else? All right, Eric says no. All right, Jesse says nope. Okay. All right, so I spent all that time recording, and I will still spend some more time recording. So I'm not going to go through this complete lecture, because I know y'all don't want to sit at home and go through this complete thing there. But I do just have a couple of things that I do want to mention here. And so just a couple of things just to remember. Your purpose with your 12 lead is to be used as a diagnostic tool. Localize the heart muscle injury site and identify the cardiac abnormalities. The 12 lead can show you more than just, MI, but for us in the field, it's going to be super duper important that we are able to identify that in the field. My technology skills have not gotten any better just because I'm sitting at a computer here. So your standard records 12 leads at the same speed. There are 15 and 18 lead ECGs. It's not something that we have, though. All right. Another thing that is important is going to be understanding the lead placement in the area of the heart viewed. And this is something that I've kind of honed in even from the first couple of days where we were talking about doing 12 leads and when you had to check off on the placement. Essentially, the placement is going to be just as important as the sheet itself or the print off itself, because you can get total different variances of ECG waveforms if you're off from the appropriate placement. Don't just slap them on. Make sure you put them in the right place. Another thing to understand on your 12 lead, and I'm sure every one of you guys who has done a 12 lead, is that they're much more sensitive to artifact and to movement and all of that as than just a lead 2. So if you do a print off and one of your leads is not showing, remember you want a full lead set. So you need to figure out what's going on and why they're not printing off, because there's really no point in doing a 12 lead if you're not going to get the full aspect of it. I did, because I'm recording and all of that, I didn't play the videos, but there is this 12 lead introduction video that I did place on Canvas for you guys. And so, yeah, Walker logged in, so we're good. Yes, ma'am. All right. All right. So I just got the word from the dean that you can use your school email. They fixed the problem for our future stuff here. Okay. All right. So again, my saying there is to know what's abnormal, you need to know what's normal. So most of your ECGs are going to print off a monitoring lead when you print it off, or if you're using a monitor, you should have a lead 2 monitoring, so you should be able to know kind of what your baseline is. But the point here is that lead 2 only gives you your arrhythmias, your monitoring stuff, and your lethal arrhythmias, whereas you're going to get a more robust view when you look at all of these. And so again, remember, leads 2, 3, and AVF, that's your inferior leads. 1, AVL, that's your high lateral leads. V5, V6 is low lateral. V1 and V2, that's going to be your septal leads. V3 and V4, that's going to be your anterior leads. Also, just know this, very important again, that your leads 1, 2, 3, AVR, AVL, and AVF, they record off a frontal plane, meaning that they record up from down to up or up to down, and then V5 through V6, they record on the horizontal plane, so they go from the inside out, which let me see if so here's this picture of this so the frontal plane. So if you were to do lead 2, your negative is here. Can y'all see my mouse cursor?
Yep.
Okay. All right. Yep. So your negative is here and your positive is here, right, at a 60 degree. So that's going from top to bottom. Whereas your horizontal, your V1 through V6 is going to be there. So they're all going to go from the negative, a central negative, to 6 positives. All right. And that's what I was showing you guys earlier. Remember, your leads 1, 2, 3, and your augmented leads, they make up the hexaxial reference system. That's where this actually becomes important. All right. Any questions so far on any of that? Again, I've got it all posted, so that's why I was just trying to, use the time wisely that I've got you here. And then, not yet. Okay. All right. Another thing that I had mentioned, and I always mention, is that let's just say that this arrow right here. When is all the videos need to be watched? Some are pretty long. By the end of next Tuesday, that's really what we had planned for. That's what we had planned for 12 leads. So I'm going to try to keep on the schedule the best I can. So all of this stuff needs to be done, by next Tuesday. But this right here is what we would call a vector, which is represented as an arrow. A vector is going to be a combination of all of the axes together that form one single line. So anytime the conduction moves away from a positive, is going to be negative. All right. Anytime it moves towards a positive is going to be upright. Now, what you have right here is what's called a biphasic. In this case, it's called an equilateral waveform. An equilateral waveform. So what that means is that you've got pretty much an equal, upright, and negative waveform. All right. So the way that I describe it is that this is essentially perpendicular. So the conduction is going in front of it, and so it's picking it up as a positive as it's coming towards it, and then as it goes away from it, it's negative. All right. So imagine that you're standing at the edge of the road. Imagine that you're standing at the edge of, let's say, 431 right outside of here, and there's a log truck coming, and you're looking directly at the road. So the log truck is coming from my right side, and as it comes towards my eyes, it's getting bigger and bigger and bigger, more positive, until it hits that middle point. And then once it hits that middle point, it's going to start going away from me, and it's going to be getting more and more and more smaller, or more and more negative. So that's essentially what's happening with a perpendicular lead right here. As it's coming towards it, it's positive. As it's going away from it, it's negative. So again, that's not going to be that, that's certainly not a big deal there, especially in a 12 lead when you do have perpendicular leads. Now, based off of the way the axis is going, a lead 2 shouldn't always, a lead 2 really shouldn't have a equiphasic lead, or an equiphasic waveform. But if you do see that, that's certainly not anything that's diagnostic. I just, wanted to make sure that you understood what you're looking at when you see that. So that's pretty self-explanatory. Any questions? All right. Moving on. Maybe. So remember your precordial leads, that's what we're introducing into 12 lead here. That is your vector. They're also called vector leads, V1 through V6. So this is a cross section where we're looking, and you can see that all of these would have the same negative, and they're just taking a picture of that conduction from their viewpoints. All right. So V1, V2, V3, V4, V5, V6. So V1 and V2, they're looking at your septal wall there. V3, V4 would be looking at your anterior wall. V5 and V6 are looking at your low lateral wall. All right. So they're looking through the myocardium, whereas 1, 2, 3, AVR, AVL, and AVF is really looking more up and down through the conduction system itself. So that's why 12 lead is important, is that you're looking through the myocardium, you're looking through the tissue to see if there is MI and all of that. All right. There's a lot of repeat stuff in this PowerPoint because I want to make sure that you do see that and all. I've went through most of all of that already. So let me just take a minute just to try to live this stuff with Axis. So you know that through the process with the electrical conduction, through that process, it's all or nothing, and it's through a conductive system where if I have a cardiac cell that depolarizes, the next one to it's going to depolarize, and so on and so forth. So what you actually have is a whole bunch of cardiac cells together that are sort of having a electrical charge at a specific moment. But what has to happen electrically is that all of those electrical charges have to be able to kind of get together to form one general direction. And that's where your axis of depolarization or your cardiac axis comes from. And that's what I was talking about. So normally the electrical conduction should start and it should travel in a direction of about 60 degrees. All right. Now your other leads are measuring it from their angles, from their lead axis, but you should have, if this heart was pumping right now, you should have it pumping at a rate of or at an axis of about 60 degrees. All right. Each one of these arrows is what's called a vector, or the value of the electrical charges from all myocytes at a specific moment. Anything that's going to have force, magnitude, and direction is considered a vector. In the case of the heart, each one of the cardiac cells is considered a vector. But if they weren't able to get an axis there, then you would just, that's what happens in like fibrillation. You've got a bunch of vectors firing off, but they're not able to get an axis going. All right. Now, the thing about cardiac tissue is that if you think about cardiac muscle, just like it would be, think about it just like um, skeletal muscle. The bigger it gets, the more nutrients or the more it's going to require. And so, cardiac muscle, as you start getting areas of hypertrophy, such as like when you have cor pulmonale, where the right ventricle starts getting bigger and bigger because of the thoracic pressure, or right ventricular hypertrophy, it's actually going to require more electricity to pump that thicker tissue. So then you may actually have the axis being drawn towards that area of hypertrophy, or that area of more tissue. So that's where you might get an axis off a little bit. Now, does that always mean that you're going to have a person with severe cardiac issues? No, it doesn't. But that's where this whole concept of axis comes from. Now, think about in the case of MI or the case of infarction, that's going to be very important there, where it is full-blown injury, then infarction, you're actually going to see the axis be pushed away, because that myocardial tissue cannot use the conduction that's coming towards it. It actually deflects it, and so that could cause axis deviation as well. All right. So again, this is this should be about 59 or 60 degrees. This arrow right here is your normal axis, is going down, and it's finishing in the ventricles. All right. So with your axis views, man, it's a lot easier to do this on a board, but with your axis views, let's see, I think I can write here too. All right. So your axis views, so this is lead 2, or I'm sorry, this is AVL at 30 degrees. All right, this is lead 1. All right, this is lead 2. This is AVF. This is lead 3. And then this is AVR up here. All right. So the positives where the end of the arrow is with each one of these. So again, it's looking inferior, and you notice here the way they've got this picture looking, it actually is saying that the inferior is a lot of the right ventricle. But if you are thinking about how conduction goes, again, you've got your SA node, AV node, then to the ventricles, should go about this 60 degrees. So in lead 2, it's going to have a positive QRS deflection if it's going that way. All right. So if you look at it in a quadrant system, so 0 to 90 degrees, 0 to 90 degrees, this area right here is going to be normal. All right. So if you've got conduction that even goes this way a little bit or down this way, that's still going to be considered normal. All right. And this right here from 0 to negative 90, this is left axis deviation. So this is going to be, let's say that you got some infarcted tissue here, and you've got some infarcted tissue down here, and you're actually being deflected, and the conduction's going that way. I need to use a different color, Donna. Then the axis may go up this way. All right.
Nick, how would we recognize that on a strip?
I'm going to show you in just a minute. Looking at leads 1 and AVF. And obviously you could also look at the axis of that's printed off, because your strips, most of your 12 leads actually give you a QRS axis as well. They take all the work out of it. So in this quadrant right here, though, from positive 90 to positive 180, you've got right axis. So let's say that you've got a huge right ventricle, and so it's requiring more of that conduction. So what it's going to do is actually, from your normal conduction, it's going to defer the conduction to the right side, which kind of neglects some of the left side, so you don't get as good of a pump. All right. Now, the worst of it all is going to be from negative 90 to I guess they do negative 179, but 180. And that's going to be in this area here where AVR is. So in most cases, you should always see a negative deflection of your QRS and AVR. Why? Because the positive is always going this way. But this is called ERAD, or extreme right axis deviation, or no man's land, or I don't ever want to see any conduction going this way. Why? Because something's happened down here. Most cases it's been AMI or something like that, to where my conduction's being deflected back up, and I'm really not getting a good push out from the bottom there. All right. Again, I know that this is amazingly confusing. And so that's why I did post those other links. That guy, he does explain it really well. But to answer your question, Eric, one of the ways that we will determine a QRS axis is to look at lead 1. And then look at lead AVF. And that's because they are at the ends of the normal quadrant there. All right. So I'm going to look at my QRSs, and I want to, in lead 1 and AVF, I want to look at my QRS, and I want to see, is it positively or negatively deflected? So if, let's say that this is normal conduction systems up here, SA node, and I'm moving down AV node, and then ventricles, and I'm going towards this way, so I'm going downward and leftward, then I'm going to expect my AVF to be positive and my lead 1 to be positive. Why? Because I'm going downward and leftward. My axis is going downward and leftward. Now, what if I have a right axis deviation? So now I've got my conduction, and for whatever reason, my axis of depolarization has now been pushed downward and rightward. So I'm going away from my left side, which is where my lead 1 reads. So I would have a negative lead 1, but a positive QRS and AVF. Okay. Now, what about if I got deflected to the left side? All right, so I've got my conduction And if I've got my conduction, and now I've been deflected leftward. Okay. But I'm going upward. I'm going away from AVF. So I'm going to expect my lead 1 to be positive. But I'm going to expect my AVF to be negative. All right. And so that just leaves us with ERAD, or extreme right axis deviation. And I've been deflected back this way, and I'm going rightward and upward. So this is not what I want to see, but I would have a lead 1 that's negative and an AVF that's negative. So that's the quick and easy way to determine that. I say easy right now. I know y'all just got a view of my big old head, but I know I say easy right now, but it is. Once you actually are able to sit down and really look at it. But that's the quick and easy way that you would determine it. You're not there. It's actually a mathematical formula based off the size of the waveform, and all of that, to actually, for you to be able to figure out how to get a actual number for your axis. And that certainly, this is barely something that, and I wish I wasn't recording and saying this, but this is barely something that's really significant for us as it is. So let alone actually figuring out how to calculate the numbers for axis, that certainly be a waste of time when I've got other things that I need you to be able to figure out. So, but it is part of the learning curriculum, and there may be questions about axis on there. So, I definitely look at the axis and what causes the different axis deviations and all of that. So, does that answer your question, Eric? Yes. Okay. All right. Where are we at on time? All right. So, the one of the other things that I wanted to mention right now, and so this is essentially where I'm gonna stop after we look at this, and then you can I'll post the lectures for next week over the next day or two. But I just wanted to look at a little bit of ischemia, injury, and infarction, and as far as like ST elevation and all that. And then we'll really get into that next week. Well, you'll really get into it with the lectures, and then I'll give you a little bit of an overview of it next week, as far as treatments and all of that. Okay. And so, with ischemia, injury, and infarction, understand that there is a progression there. And that's our biggest concern. You got to be proficient in this area. You do not want this MI to extend, okay? So essentially, you've got damaged areas, you've got the infarction area, you've got the injury area, and you've got the ischemia. So the ischemia is reversible. If we can get somebody oxygen, now again, this is not a oxygen issue per se as far as the body's availability of oxygen. It's more of a delivery of oxygen issue. So adding more oxygen onto the patient is not going to solve this situation. It's an occlusion type issue. So we do need to get those cells more oxygen, but we get the cells more oxygen by opening up the vessels. But ischemia, again, that's just going to be lack of oxygen, whereas injury is, hey, we do have injured tissue now, but it could possibly be reversed. But then once you get to myocardial necrosis, that's where you've got infarction. So that's where you've got cell death that cannot be replaced. So here's the deal with this, though. Our goal really is to reverse this area. All right. But even if we can't necessarily just go in and fix things, we can do stuff to try to keep the infarction area from being extended. So Jesse, I just got that. I addressed that with him this morning. And I'll talk about that right before we go. So our goal here is to keep the area of infarction. It's kind of like we'll call this right now the area of COVID-19. We don't want this area of COVID-19 to get any bigger. Is that too soon for that? I don't know if it's too soon for that or not, but we don't want this to get any bigger. Okay, so I guess we're going to self-isolate. But we're also going to try to get the supply to the heart better there. Okay, so our goal here is to minimize our goal is to minimize treatment time, essentially. Your goal is EMS to balloon time, so you're going to be probably one of the first people that you need to that will be the patient's advocate in this situation and really let them know what's going down. But the door to balloon time, that's the time that they show up at the hospital for definitive therapy, and then the door to needle time. So the door to needle time, there's going to be an important issue with you there in the fact that you need to do a fibrinolytic checklist with every single patient that you suspect has STEMI. Not every patient that has chest pain is going to get thrombolytics, but we're not going to be the ones that determine that. We're going to be the ones that go ahead and get some information available. Our goal there is going to be to minimize a MI patient's time in the ER. So we do that by getting a good 12 lead, by submitting that 12 lead, doing a good assessment, and doing that thrombolytic checklist. All right. So Dom, yeah. So basically, if we know that the electrical impulse should be negative or positive in a certain lead, any change other than the normal pathway indicates some sort of pathway blockage or reroute. I guess, yeah, for the too long didn't read version of it, yeah. There's going to be, a little bit more that goes into that, but yeah. There is some things that you want to look for and all of that as well. But yeah. If we know that electrical impulse should be negative or positive in a certain lead, yeah, I mean, when it comes to your axis and stuff like that, certainly so. And actually, whether it's negative or positive for like bundle branch blocks and stuff too. Okay. I'm so ADD with this. It's bad enough when I'm in a classroom with nothing to distract me, and now we're in here. All right. So again, just remember, one of the main reasons why you have that severe chest pain, why you have the issues, is that you're actually, as you're being deprived of oxygen, those cells are not only just dying off and affecting the way the heart pumps, but they're actually metabolic processes that are occurring just like with any other muscle whenever you start working it to the max and depriving it of what it needs. And so obviously when they're deprived of oxygen, you go into anaerobic metabolism, and the byproducts of that are those harmful metabolites, those harmful the lactic acid and things like that leads to cell death. But before it does, it leads to that severe chest pain. That's why you have, the severe chest pain and all of that. This occurs on a continuum. All right. So we know that not every patient reads the textbook. Not every patient is exactly the same. Not every patient's going to have ST elevation and all of that. But we do want to be monitoring for that. And once we have any indication that they may have chest pain or something like that, we want to monitor their 12 lead and all that. So in your normal state, your ST segment is going to be baseline there. And then once you start becoming ischemic, you may actually see a flip of the T wave. Remember, the T wave is one of your most dynamic waves. You may see a flip of the T wave. You may also see ST depression. So you find your J point and you find your isoelectric line, and you've got ST depression and a flipping of the T wave. Now, once this T wave becomes flipped, it really doesn't, it doesn't flip back. All right.
Is the flip because of the ischemic area, it's not able to conduct the pathway properly?
That's exactly right. You have these changes in the T wave and the ST segment because of the inability to go down the normal pathway. So yeah, essentially what you're looking at is an alternative pathway.
So the more injury there is, the more that pathway has to move in a different direction, and then that's what's causing.
Absolutely, and that's what as it becomes, ischemic, you've got that flip. But then as you get injured, that's exactly right. It's slowing down, and it's going through alternative pathways, to the point to where your T wave actually begins to start merging over. You actually get this ST elevation that starts to occur as you get to injury. All right. But now, one of the other things that you need to notice here is that you also have the development of a Q wave. So remember, you don't typically have much of a Q wave. But once you start seeing ST elevation and the development of a Q wave, that's not a good situation at all. That is a very bad situation. Okay. Now, sometimes,
Nick,
hey,
is on the bottom of that scale there where we're seeing severe ST elevation, is that what the video referred to as the firefighter hat or the tombstone? Okay.
Yep. Yep, because the old leather firefighter helmets, that's the plaque right there. And then that's where the head goes. Or, yeah, the tombstone there as well.
Okay, thank you.
And that's what a lot of, what?
Okay, so will the degree of elevation always correlate with how much injury there is, or will there be much variant there?
So there's no way to say that it's going to be exactly this many millimeters or this high. What in our case, what we need to do is say, we need to treat any type of ST elevation as if it is the big infarct. Does that make sense? So no, I can't necessarily say that, if it's 4 millimeters, then it's going to indicate a higher level of injury or whatever. What we do look for is at least 1 millimeter off of baseline in your limb leads, and at least 2 millimeters of baseline off of your chest leads. Does that answer your question?
Yeah.
Is that Jacob? Cool.
Yeah.
All right. But I tell you, but the development of Q waves, Jacob, will give you an indication that you are in pretty much a bad way once you start seeing these Q waves. And how do I know this is a Q wave versus like an equiphasic? Well, we know that no matter what, the first downward deflection after the P wave is going to be a Q wave. That's back to basics, on wave identification. Now, sometimes you may have what's called a physiological Q wave, where once a Q wave develops due to an MI, an older MI, it usually stays. But the only way that it can really be said that is a physiological and not a pathological, meaning disease, Q wave at that point is without the presence of ST elevation and without the presence of chest pain. So that's kind of a gamble that we don't really want to play there. If somebody's having chest pain and they've got Q waves and all that, we don't want to say, hey, that's from your old MI or whatever. So, does that make sense to everybody? I hope so. Will the Q waves always be a downward deflection? Yeah, and that's what I was just saying. Your Q waves are always going to be the downward deflection, the first downward deflection there. So if you notice here that Q wave is pretty significant compared to when up here when you didn't have anything. The other thing that you want to notice about your Q wave, so the rule on identifying the Q wave is that it's got to be at least 1/3 the height of your R wave. So at least 1/3 the height of your R wave, and that's how you're going to determine that is a Q wave that is, starting to become deflected off of abnormal pathways. Okay. So we definitely want to remember this progression here. Early on, when you have ST depression, T-wave flip, then that's going to be earlier states. So even in this ischemic state, even when you've got lower lower ST elevation, and it kind of goes back to Jacob's question just a minute ago. For me, I'm not comfortable saying, hey, that if I see a ST elevation there, that I'm not comfortable just saying, hey, that's just ischemia versus injury. I'm going to treat it the same, but hopefully by the interventions that we do in the field, we could, if they're still in that ischemic phase, hopefully we could reverse those issues. So, all right. So, and again, this PowerPoint covers a lot of that there. I was just giving you the lowdown on that. And here is what I was talking about just a moment ago with the Q waves. You've got your normal Q wave, but then you've got this Q wave here that's much bigger. All right, and here's just another on just to print out down here, especially in your lead 3 and AVF. You've got those. Now, if you look in AVL right here, if you look in AVL, you don't have a Q wave. All right, and so this is a good thing here for me to point out to answer your question, Leanne. You've got your Q wave here because in AVF and leads 3, because it's your first negative deflected wave past the P wave, whereas your first wave after the P wave in AVL is upright, so that's going to be considered an R wave. Okay.
So in AVL, there is no Q wave at all.
Nope.
It's always going to be an R wave in AVL.
Just not in you may, yeah. I mean, you definitely may have Q waves in AVL if you have like a high lateral MI or something like that. I'm just talking about on this particular slide outline right here.
Okay, I was just making sure it's not always going to be AVL, not going to have a Q wave.
No, definitely not. That's not the case. Every one of your leads on a 12 lead is dynamic. You may have issues there. Okay.
Okay. All right.
So
we're looking for those like particular abnormalities in those certain like groupings. So like lateral, inferior, anterior, septal. So if we're seeing it in like certain contiguous leads, then that tells us the portion of the heart that's ischemic or infarcted.
Yes, to a degree, yes. Again, using legalistic speech here, this can really only tell us what's happening with the electrical conduction, but we can use common sense and critical thinking and say, hey, if leads 2, 3, and AVF are showing these issues, then it's pretty safe to assume that there is muscular damage or muscular issue in the inferior portion of the heart, and so we're going to treat it as such. The only way to really determine that is if they go to the cath lab.
Gotcha.
Okay. All right. So the critical thing here, though, to be able to determine that is to actually know where your J point is, and to be able to determine your J point. All right, and then being able to see your T wave as well. And so this is just showing just some different examples here of what you may see based off of inferior or this is actually an anterior wall and a septal wall. And so I've got ST elevation in V1 through V4. And then this is a lateral, so I've got some issue in V6 and V5, and then if I had my full 12 lead, I'd probably see a lot of probably some ST elevation in leads 1 and 2. All right, and so this is what I was mentioning just a minute ago. It needs to be at least 1 millimeter above baseline in your limb leads, and at least 2 millimeters above baseline in your chest. But any patient that has chest pain and they are feeling they're feeling chest pain, and any patient that has ST elevation and all that, we're not measuring boxes and all that. We're taking it as it is, and we're moving forward with treating them there. Okay. All right. So these graphics right here, what time did I tell you we'd be done? 10 or 10:30?
10:30.
Okay, thank you. So as far as reading this strip, and I already went over some of this with that first activity that we did, but as far as reading the strip and all that, you definitely want to make sure that you got all your leads printed. You want to make sure that you got Artifact not on there. If it is, you need to stop everything you're doing, have your patient sit still, have your driver stop the truck. If you your best your best MO here is going to be, if you got a chest pain patient, as soon as you make contact with that patient, start putting that 12 lead on. That way you can get it transmitted to the hospital immediately in that setting, because you need to get a baseline. As I showed you just a minute ago, if you got ST elevation, then you want to see, or even ST depression, you want to see if there are those changes that are occurring. So, you want to do one probably in the case of severe chest pain. I would do one at least every 5 minutes or so. All right. Is there Artifact present, and is the rate at one of the extremes? Now, also, as far as interpreting it, you're going to follow your same rules, but by the time you got a 12 lead, you've probably already run your lead 2 and at least got your monitoring rhythm. But then our main goal is to look at the J point, look at, do we have ST elevation, ST depression? That's going to be our big issue there, our big thing that we want to look at there. All right, so again, another good graphic here kind of showing you where what I've already talked about. No matter where you're at, you should have the same printout. Leads 1, 2, 3 on this side, V4, V5, V6, and everything in between. All right. So one way to help you remember it would be, I see all leads. Now, it doesn't necessarily go in the same order, but I would be inferior, which is leads 2, 3, and AVF. C would be septal, which is going to be V1 and V2. Now, this graphic also, again, goes back to what Don was asking, I think, or somebody was asking just a moment ago, could our V1 and V2 kind of considered anterior? And they are on the anterior wall. They're just over the interventricular septum. A would be your anterior, which is V3 and V4, and then leads is going to be your lateral, with 1 and AVL being high lateral, and V5 and V6 being low lateral. All right. So your inferior wall, that's leads 2, 3, and AVF. Your camera is essentially at the bottom there. All right. I felt like that was a good graphic right there to show you that we're taking the pictures at the bottom of the heart. Whereas your high lateral wall, that's AVL and AVF, that's going to be up here. And then your low lateral is going to be down there. You'll see a picture of that in just a minute. Your septal wall right there over your interventricular septum, which is lead 1 and lead V1 and V2, which that's about where you would place those. All right. From that placement, they look through the right ventricle and see the septal wall. The septum is left ventricular tissue, though. Okay. Then V3, V4, the positive electrode for these two leads is placed on the anterior wall of the left chest and correlates to their designation as anterior leads. All right, so that's where your camera is there. And then your low lateral wall, that's going to be V5 and V6. So that's where your views are. So your camera is looking at the same conduction, just through several different angles. Okay, any questions on that? All right. So
when you're looking at the leads, if you suspect anything on the right side more than the left side, would you transfer from the leads V1 through 6 to the right? I mean, to the left side.
Right side. No, because You would just move V4 over. You could move V5 if you wanted. You could move them all, but for really what you need, you just need V4 because all you're really wanting to do is indicate if you've got ST elevation, on the right side. Because if you got ST elevation on your right side, you're not going to administer nitrates, but your treatment for everything else is going to be the same. Does that make sense?
Yes, sir.
Now, if you do notice ST segment elevation on the right side, you may want to, if you're doing serial 12 leads or every couple of minutes or so, you may want to move them back and forth and do a left side and then a right side right afterwards. But be sure that you mark your right side V4R so that you don't get the two confused.
Okay.
Okay.
Yep. Thank you.
All right, so I mentioned the contiguous leads. Then lastly here is the reciprocal changes, and that's just going to be the mirror image. So if you can just imagine your camera is on one side of the heart and the camera is on the other side of the heart. They're both taking a picture of the same conduction, but one has one image and one has the back side of the image, and that's essentially the same thing. Now, your leads 2-3 AVF to leads 1 in AVL, leads 2-3 AVF to V1 to V3, and then V7 to V9. Now, I mentioned earlier, one of your limitations of the 12 lead is that you don't have a posterior view. But if I have ST depression in leads V1 through V3, but I do not see any type of ST elevation in 2-3 AVF or anything anywhere else, then it would be pretty safe to assume that had I had the ability to put V7, V8, V9, which are your posterior leads on, that I would probably have ST elevation in those because of seeing what I know as the reciprocal changes in V1 to V3. Okay? And this is just an example of you've got one image on this side and one image on that side. You've got essentially just the mirror image of them based off of what's going on there. All right.
Can you repeat that V7, V9 stuff again? That you lost me on that one.
Okay. So we know that your 12 lead only goes to V6, right? Which is your lateral wall. You don't have a posterior wall lead in your normal 12 lead. Now, there are some machines that do a V7, a V8, and a V9. So they have the leads and the lead wires, and they just go on around the back to get the posterior part of the left ventricle. And so if you can think about where V1 and V3 would be, which is your anterior, essentially, then V7 and V8 and V9, that's your posterior. And so if I've got posterior ST elevation, meaning, or if I've got, STEMI in the posterior, then I could expect to see ST depression in V1, V2, and V3 because ST elevation is going to show ST depression in the reciprocal leads. So V7, V8, V9, and V1, V2, V3 essentially are on the opposite sides of the heart, looking at the mirror image of the conduction.
Gotcha.
So here is just another example of your reciprocal leads. If you notice here, I said that 2-3 in AVF and AVL and lead 1, they're reciprocal. So 1 in AVL, they have ST elevation. So I'm going to go look at 2-3 in AVF, and they've got ST depression. So that is another good confirmation that I do have a high lateral. Now, what I'd want to do is go ahead and do a 12 lead and look at the other parts of the heart as well, obviously. But those are reciprocal changes there. On the flip side of that, if I had ST elevation and leads 2-3 in AVF, I could expect ST depression in 1 in AVL.
Would the treatment for the posterior ST elevation be the same as anterior elevation?
Yep, chest pain protocol. Yes, sir.
Usual.
All right. So your 5+3 approach, you go through all of your normal steps. You've already done that at this point. Then, of course, we're looking for ST depression, ST elevation, and Q wave. All right. So this is kind of where I stopped off on the lectures. And so this is where I'm going to stop off on this now. Just making sure that I was still recording.